Jordana. Okay, we'll start in about another minute. Let me see if I've got quorum. Nope, not yet. 1, 2, 3. Brent is on. Okay, we have Brent. So I think, and there's Jeannie. And I thought I saw, there's Greg. Chewing his last few bites of lunch. Oh, good. There's Dr. Kurt. I think we do have quorum. So let's go ahead and get started. And with that said, I'm going to go ahead and call the meeting to order. We've got a pretty packed agenda today and a lot to get through. So what I'd like to do is, who wants to take attendance? We'll just say who's on. So it's Marky Butler, Linda, Jeannie, Tori, Greg, Dr. Kurt, and Brent Miller. So we do have quorum. And the alternatives that I do see on is Patty Clapper. And that is it right now. So the meeting has been called to order, and let's see if we have a motion to approve the minutes of the previous meeting that Greg so gracefully chaired. Thank you.
I'll move to approve them.
Thank you.
Second.
Thank you very much. Any changes or modifications? If not, please raise your right hand. Dr. Kurt, were you fine with the minutes? I'm going to assume that he is. He's frozen. Okay, moving on. Okay, can we pull up the agenda so we can all have that in front of us as we work through this? Okay, thank you. Whoops, I just lost it. I don't know what's going on. Here we go. Introduction of the U.S., Colorado, surrounding counties, and Pitkin situation overview. Charlie, you're up. Thank you very much, Charlie, for all your hard work.
And Marky, I'm going to just jump in really quickly. I think I have one slide before Charlie's, sorry.
Oh, okay,
Yeah.
Go ahead. Karen?
Thank you. Thanks, Lindsay. So I just wanted to kick us off today. Someone reminded me last week about the amazingness of SARS-CoV-2 as a virus, all that we are learning through science and collectively as a global community around this little virus and how it has had such an impact on our lives in a lot of different ways. And they reminded me that it is, as we go through this process of understanding SARS-CoV-2, that there's a sense of, having humility toward the virus and having humility toward the new knowledge that we gain. And it was a good reminder of me. It's easy to sometimes feel like we want to have certainty in a very uncertain situation. And at times for me, that can make me feel pretty rigid in my thinking. And when my friend reminded me that humility is such a great, intellectual humility in particular, such a great way to kind of approach where we are. And I was thinking about this Carl Sagan quote, that really in science, it really is a voyage into the unknown. There are a lot of things we don't know. There are a lot of uncertainties moving into the future. And if we have humility around that, if we're able to learn and pivot as we move along, and I think some of the things that we'll be talking about today with mask is one of those places that just collectively we've learned so much more about the virus, asymptomatic transmission, transmission within younger adults, and really thinking about the aerosol and the airborne nature of the virus. Like these are all new learnings, and it shifts the way we think about the strategies that we should approach and implement based on that new learning. And to really kind of for me to have that humility of like, wow, we may have been wrong about this, 3 months ago or 4 months ago collectively. But we've learned some things, and how do we apply that learning to then new strategies or ways of looking at our strategies differently? And so I am really trying to cultivate that as I move forward. And so again, you'll hear some of the changes and shifts. We talked about it at the last Board of Health meeting as well, as we'll shift strategy as we get more and new information, and we want to be able to pivot pretty quickly and be flexible in our thinking and in the way we do business, and in the way we try to promote health in our community based on new information. And so I just wanted to frame up our meeting that way to begin with, because we will be talking about some shifts in our strategy moving forward. And now I'll turn it over to Charlie and Kim and Josh.
Okay, go ahead, Lindsay, one more. So we're going to talk a little bit about the history of quarantine here just for a second. The first record of quarantine for infectious disease dates back to biblical times in the book of Leviticus. And Mosaic law at the time was actually really specific. It's very interesting. It said, if a shiny spot on the skin is white, but does not appear to be more than skin deep, and the hair on it has not turned white, the priest is to isolate the affected person for 7 days. Kind of sounds like our public health order, right? Modern day quarantine derives from the Italian word meaning 40 days. And it came about because they wanted to quarantine, make all ships that were coming to Venice at the time, quarantine or stay offshore for 40 days before passengers and crew could go ashore because of the plague epidemic. So that was back in the 14th and 15th century. Here in the US, Congress passed the first federal quarantine legislation in 1878 to prevent yellow fever, and 1892 to prevent European passengers from bringing cholera into the United States. So I bring this up because of the important role isolation and quarantine are playing today. And this is an interesting picture on the slide. You can see the folks on shore, not wanting cholera to come onto shore. So who do they send out? They send out the Board of Health in the little boat there that's going to protect all the people from the evils of cholera coming on shore. Next slide. So I wanted to put our data in context before Josh breaks it down to what's happening nationally in Colorado and in our surrounding counties. Globally now, infections have passed 15 million and over 600,000 deaths. This chart here is for the US, and it shows that cases are rising again, maybe starting to flatten a little bit after the 4th of July gatherings, which now we have 4 million cases and over 145,000 deaths. Next slide. Hospitalizations in the US are also increasing and are stretching our resources in some of our surrounding states, as we see on the news every night. And we're again seeing an increase in deaths due to COVID-19 in the US, as shown on this chart. You can see that it's just starting to go up. So cases, hospitalizations, and deaths are at concerning levels, particularly in our surrounding states, and in particular, Texas, Arizona, and California. Next slide. In Colorado, the trend in cases has been increasing since the middle of June, with lots of ups and downs, but again peaking about mid-July, which you'd expect a couple weeks after 4th of July. More than 41,000 people have been confirmed to have contracted the virus since March. Next slide. So I know that this group likes, more sophistication in the data. So this comes from the School of Public Health modeling that was produced for CDPHE and the governor. And it shows the trajectory of hospitalizations depending on social distancing levels. In June, the blue line that's in the middle there, we were at about 66% in terms of our social distancing by their measures. And hospitalizations were pretty flat or increasing in just a manageable way. But what they're seeing now is, as we get into July, is we're kind of throwing caution to the wind in terms of social distancing, and which is they figure is down to about 41%. And the projection hospitalizations have increased dramatically and are projected to increase even more. So the message that they're trying to get across to all of us is this is not the time to let our guard down, because it can really have a significant impact going forward. Next slide. So the good news, I guess, is although hospitalizations have increased, in Colorado, deaths have not followed that rise in infections to the same degree. And I'm going to let Dr. Levin comment further on this, but it may be a combination of, we've kept our cases to a level that's protected our healthcare system. It hasn't become overwhelmed like we've seen in Texas and New York, and now approaching in California and Arizona. It may be also changes to the virus itself. And certainly it's been because our hospital doctors are getting better at treating and managing COVID-19 as the pandemic progresses. So we're just not seeing people, die quite as frequently. Next slide. So that's Colorado. Now let's kind of turn to our local situation. So this is Garfield County. Garfield has seen a significant increase in cases, particularly for the 2-week period from June 24th to July 7th, where they saw 137 cases. And their current 14-day positivity rate is 10.2%. We've heard anecdotally, that in some areas like Mountain Family and a couple others, the positivity rate's even higher. On July 1st, their case count was 298. Today, it's 561. So they've had an 88% increase in 3 weeks in the number of cases. In Garfield's situation, as you know, is important to note because many of the individuals in Pitkin County's workforce reside in Garfield County. Next slide. The other area that we have to keep an eye on is Eagle County in the Elgin, Missouri Heights area. We don't have a breakdown of that, but we can look at Eagle County as a whole. And they've announced recently that they've moved into the red zone, into their concerned phase, with 73 cases reported in a 5-day period and a positivity rate of over 20% during that time. On July 1st, Eagle County's cases were 692. And today they're at 884, which is only a 28% increase, which is a lot less than Garfield County over those 3 weeks, but still concerning to them. So obviously concerning to us as well. So that's what's happening in those 2 counties around us. Next slide. And then we're going to take a look a little bit at our overall numbers here in Pitkin County, and then Josh is going to break them down even further. So this is the data from our testing from ABH. And we've tested, we're starting to approach 2,000 people. We've had 131 positives. Overall, the positivity rate is 7%. But a better measure of that is our current 14-day positivity rate. And that number, which I'll show on the next chart, remains higher in the current context of limited testing availability. We're not recommending testing, for example, of asymptomatic individuals unless recommended by public health or for specific close contacts or outbreaks. We're also in active discussions with ABH and other testing providers and CDPHE who accumulate electronic laboratory reporting from private labs so we can combine all those sources and in the future have a better picture of the overall testing that's going on in the valley. But for right now, next slide, this is what we're seeing from the ABH data. And the trend line that you see, the bars going up and down are the number of tests that have been done and the number of positives in the dark blue. The trend line you see is our positivity rate, and that's increasing, which is currently at 9.2%. So increasing positivity in the context of increased testing is an indicator of rising spread of the virus. So that's a concern to us. And just to clarify once more for everybody listening, positive tests at ABH may include cases that will ultimately be reported in Pitkin, Eagle, Garfield, or other counties, or to CDPHE for other countries. So this is testing data now that we're looking at. Next slide. And this, on the other hand, is a graph of new cases for people that live and reside in Pitkin County. And we've reported 27 new cases in the last 14 days, and that's just off the peak of about 45 cases a few days ago for that 14-day period. And that corresponds to the July 4th weekend. So we saw people out and about a lot more, socializing, gathering, and the cases followed. We were at 99 cases on July 1st, and now we're at 162. So we've had a 64% increase in the past 3 weeks. So we're kind of right in between. Eagle County was 28 and Garfield County was in the 80s. So we're kind of in the middle there. So ABH and others test individuals in Pitkin County, as we saw on the last chart, and report positives to us. We assign them for case investigation and contact tracing. And it may turn out that a case is eventually assigned to Garfield or Eagle or another jurisdiction so that they're not double counted. That's the rule that CDPHE came up with to avoid double counting. But we do keep our eyes on and communicate regularly with our adjoining counties to coordinate and understand how and where the infections are originating and to coordinate containment. So even though a case is maybe assigned somewhere else, we don't lose track of that. So in the context of mitigation strategies that we're going to be talking about, regional cooperation is really important because that's how we have to keep our eye on the virus. Next slide. So this is interesting. Also in the context of potential mitigation strategies going forward, you might recall that I showed you this chart on the left on June 25th. And it's a chart of the theoretical risk exposure to COVID-19 from commuters, tourists, and visitors, depending on their point of origin. And this calculation computes the risk to a Pitkin County resident of random contact with a person from various points of origin based on the number of individuals traveling here and the prevalence of disease in that point of origin. So you can see at the top of the chart a month ago were Pitkin County and Garfield County. We were more likely to run into somebody that's positive from our own county or from a neighboring county. Today, this past week, when we ran the chart, Texas is at the top. Florida, California, other parts of the US are all up there. So what it's telling us is we're bringing a lot of visitors into our county and they're coming from areas that have a high prevalence of disease. So that increases our risk exposure here based on that kind of calculation. So in terms of the context of mitigation strategies, we want to get the word out, and we prefer that it come from the state level as well, that people shouldn't come here sick. They should come here symptom-free for 10 days. We may at some point, and some states have already gotten to the point where they're asking people to quarantine when they come into their jurisdiction. I don't think we're there yet, but these are numbers that we need to keep an eye on. Next slide. So as we discussed in terms, and this is from our dashboard as well, something that you can keep an eye on. There's concerning spread of the virus in Eagle, Garfield, and in Colorado as a whole, as well as in our county. And if you look at the column that's labeled new daily cases, 14-day average, in Pitkin County, our average is now up to 6 cases per day on average. And that's still manageable from a case investigation and contact tracing for our contact tracing team, but it's moving us into a higher risk level. In order to stay within our current safer at home and in the great outdoors level, we'd like to see that 14-day average less than 6. And we're right at 6 right now. But we don't just look at that individual indicator before we would make a move. We're going to look at, even though it's a concerning metric, we're going to look at it in the context of our overall situation. Our goal remains to avoid a crush of cases, to protect our residents and visitors and healthcare system and our businesses and economy. So we're going to, look at that. We're going to talk a lot about other metrics that we're looking at as we go. Next slide. So you've all seen this. This has been shared a lot before, about wearing a mask appropriately. But I think it also, is kind of a metaphor for, kind of what happens in the evenings out and about, especially when alcohol is involved. We start out in the top left at 6 p.m., kind of move to the top right by 8 p.m., maybe to the bottom left by 10 p.m., and by midnight, we've kind of abandoned all caution. So in the context of our mitigation strategies, adherence to the 5 commitments at all times is important, as well as maybe a curfew to protect us from ourselves. So with that, I'm going to turn it over to Josh, who's going to break down the data further. Next slide.
Hey, Lindsay, if you don't mind, could you exit out of the PowerPoint real quick and restart it? I made a few changes real quick. Thank you. So as Charlie mentioned, we're going to break down the data a little bit more with our Pitkin cases here. So the first pie chart that you'll notice on the top left here is reported sex. And so we have a breakdown between male and female, with male at 57% and females at 43%, which is what we see nationwide and even statewide, that males tend to be more significantly impacted and may have higher rates of infection than females. And in terms of ethnicity, in Pitkin County, 81% of our cases have reported as non-Hispanic, and the other 19 have reported as Hispanic. And then this map over here on the right shows the Roaring Fork Valley, but really just honing in on Pitkin County. And these are the number of cases that we have information on based on based on city of residence here in Pitkin County. And so as we expect, we have the majority of cases in Aspen. We have 17 cases reported in the town of Stillmass Village, 13 up in Basalt, and that's just the Basalt that's in the part of Basalt that's in Pitkin County. And then the rest are below 5, and so we're not reporting on those numbers. Next slide. This breaks down all of our cases by occupation status. And before I talk about it, I want to make a note that just because they work in a certain sector doesn't mean that they were infected there or that it has anything to do with their infection. These are just the areas in which they're employed. And some of them it is related, some it's not related. So the highest percentage of individuals we have in terms of our cases reported as 13% reported as retired. So that's the majority. That's the highest proportion of cases by occupation or by status there. We have 11% in restaurant or grocery stores. We have 11% that are in retail or hotels, and then 9% self-employed or they're at home. So those are our 4 main categories there by occupation status. We have 21% that are unknown or pending. And that's for several different reasons. Some don't reveal employment, and then others are still pending investigation. So that's why we have 21% there. And then we just have a barrage of other notable occupations as well. We have began seeing an increase in other sectors such as construction work or any sort of work on a home or business, as well as housekeeping. We begin to see more increases there. And then you'll notice that 4% are long-term visitors. That's really referencing individuals who stay here for more than a month or may own a second home here. We count them as Pitkin County cases. And so 4% of our cases are in those long-term visitors. Next slide. So this, and I apologize, got cut off on the bottom there. This is our current turnaround time in Pitkin County. And so we start with symptom onset to specimen collection. There's an average of about 5.9 days from when somebody develops symptoms until they go and get a test. And so obviously we see some are 0 days, some are -1 days, right? They go and get tested before they have symptoms. And some are much longer, 10, 12 days, just depending on what their symptoms look like. If they have allergy-like symptoms or very mild symptoms, they might not seek testing right away, especially if they don't know that they were exposed. So on average, we're seeing 6 days. In terms of turnaround from the lab, our average is 2.9 days from the date that the specimen is collected until we receive the result. So it's pretty good. We see a fluctuation in that number as well. Sometimes we get results immediately if we're using a rapid test. Sometimes it takes many more days than that, up to 10, 12, 14 days sometimes, depending on the situation. So then adding those two up, we get 8.8 days, and that is the time on average it's taking from the date that someone develops symptoms until we receive the lab result. And that's an important number for us to look at because the sooner that we can hear about a case, the more quickly we can follow up and ensure that they are isolated and that their contacts are quarantined. Next slide. And this is just our current numbers of those who are have been asked to isolate or quarantine in Pitkin County. So we have 47 total. We have 12 in isolation, and then 35 have been asked to quarantine. And that's as of today at 12 p.m. And then last slide. And so we've had a lot of questions, a lot of individuals who have asked us for this number, and these are out of jurisdiction cases. So these are cases that get reported to us that we then refer out to either a different county, either Eagle, Garfield, or out of state. And this number really only includes those that we hear about. So there probably are more that have tested positive that have some sort of association with Pitkin. These are just the numbers that we've heard about, and these are the numbers that our case investigators and contact tracers have worked on, even though they don't count towards our numbers. We receive information on those individuals. We determine where they may have been while they were infectious, where they may have been exposed, and then usually we send that case out to the county of their permanent residence. So that's 24 cases since July 10th. So we're getting on average about 1 case a day that is an out of jurisdiction case that will not count toward our case count, but does take up time here when we're working on those cases from our end. And that's all I have for right now.
Thank you very, very much, Josh. Kim?
Okay, let me just get my get my screen shared here. You see that okay? Yep. Okay, great. Thanks, Josh and Charlie. And Josh, that the breakdowns and all that, all the data was so interesting. Thank you. Again, I think one of my big take homes is local data versus what the state reports for us. And I think continued looking at our local data is going to be very, very important moving on. So here's some more local data. Aspen Valley Hospital data I'm going to share with you right now. And then I'm going to talk a little bit after this about some science behind mask wearing, as that will be a conversation today. So this is our hospital matrix. As you have all seen before, we remain as we have been in the cautious status under the daily visits, and it's really the community testing that has put us into that, and I'll show you more data in a minute. We remain in the, comfortable status for inpatient hospitalization and for essential healthcare workers. So here is the graph on the daily inpatient total COVID positive and PUI person under investigation who are in the hospital with COVID-like symptoms. And so the hospital really remains low. Right now we have one patient inpatient who's COVID positive, and we've remained between the 0 and 1 really since mid to early June. And so the hospital inpatient status is very stable and comfortable. I do want to mention this does not show the 7 transfers that we've had. So when somebody is very severe, they don't even make it as an inpatient into this data. And there have been 3 of the 7 have been since since June 30th. There was a June 30th, a July 7th, and then I think a 17th transfer. So sicker than even the current, what would be an inpatient. The daily emergency department visits, the ED visits, we want to remain comfortable under 6. And our matrix is a 14-day average. And so we did pop above that at one point very recently, but as an average, we stay below the 6 ED visits a day for COVID-like symptom patients. The Respiratory Evaluation Center has been on a steady rise really throughout this entire pandemic when we started the Respiratory Evaluation Center. And again, looked like towards the end of June, we peaked above what our comfort level is at 10 visits a day. So we remain under 10, but I think the important thing is this constant trajectory upward and looking at Respiratory Evaluation Center visits as a reflection of who is sick in our community that requires a physician visit. The Respiratory Evaluation Center, again, is only for people who have COVID-like symptoms in our community that need to see a doctor. And then this is our daily community COVID testing, which as you can see, this is what has put us into the cautious phase on the matrix. So since the middle to end of June, we have almost consistently, we've dipped below here, we've almost consistently stayed above our 16 a day for testing. So we're doing a lot more testing. And we feel that this is a reflection and a cautious reflection for the hospital in terms of the testing. This is the healthcare worker illness. And you can see this is our less than 6 healthcare workers out. Right now, we currently have 6. What you're looking at here over the past, I think this may be at least 3 weeks, that we are right around 6 and we've gone above 6. And I wanna remind you that this graph is for all AVH employees. When we look at the matrix and we look at healthcare workers for the matrix, we're really looking at essential workers only. So there's a subset of these that are the frontline workers, which are most at risk. And that is not 6. So this is just for total workers. So that's why we remain in the comfortable phase for healthcare workers on the matrix, because it isn't 6 essential workers versus total employees. I hope that made sense. And then this is our weekly positive and negative PCR test results. And what this shows, since we really started testing at the end of April, that there's been a very, this is our negative and this is our positives, but overall we've done an increasingly greater number of tests and our curve is going even higher. So we are testing a lot, consistent with the prior graphs. Our last week, there were 20 new cases and the week prior, there were 25. So you may say, oh, well, we're trending downward. This remains to be seen. I think this is certainly looking at this bump here is certainly from the July 4th weekend. And what is going to happen from here? Are we going to continue to trend higher or go lower? We'll just have to keep an eye out on it. And I always like showing this, the asymptomatic COVID testing. And we do asymptomatic testing for pre-op, preoperative, for pre-OB induction, and then there's some others that are sent for asymptomatic testing in general, echoing what Charlie said previously, that we are not systematically doing asymptomatic testing in Pitkin County. But what this does show is that there's a 4% positivity rate. And in terms of the number of, these are the negative for asymptomatics, and then these are our asymptomatics, which have been a little bumped recently as well since July 4th. And really what's important here is that there are people who are asymptomatic carrying this disease, and this is proof of it. And so there's asymptomatic transmission, and it's more of an argument to wear a mask, even if you don't have symptoms. And we'll be talking about this later in the meeting. This Charlie presented, and again, we're up to in the state of Colorado. I just want to do 2 graphs in Colorado. This one that we are consistently up around 500 new cases a day. And I've been attending these meetings with the CDPHE epidemiologists that have explained this data. One kind of takeaway point that I wanted to share with everyone that I think is really important, and Charlie had mentioned this, the group of people who represent the greatest proportion of that 500 a day now are in this at this category, the 20 to 29, and then some in the 30 to 39. This is the group, and we think that this abrupt rise in this group in terms of cases in Colorado is most likely due to less social distancing that's going on. Now we're seeing this rise now in cases, but we're not seeing a rise in deaths, and Charlie showed that as well. The conversation that's happening at the state level, and what I agree with, is that this rise in cases, we are potentially in a lag period right now between the rise of these cases and the spread that will occur to the older population or the more vulnerable population, and people with underlying disease that may lead to increased hospitalizations, ICU stays, and deaths. And so we are really looking at this closely and seeing if that is actually what is going to occur here, which is what we do expect. So we may just be in this lag time period. We'll be looking at the hospitalization data and the death data in the state closely in the next 2-3 weeks. So I just wanted to present the AVH data and then just present a few things on the science behind wearing a mask, since this is going to be an important topic today during the Board of Health meeting. We'll be discussing wearing a mask. And I really wanted to look at what is the current science behind wearing a mask. We know that it's evolving. We know that we're still very early in the pandemic, and there's not a lot of research out on wearing a mask and the transmission of COVID. But all of the research that is coming out and the modeling, and some of the modeling that I'll show you, is proving that it is an effective way, that there is science behind wearing a mask, that it decreases transmission. These are all the organizations that recommend wearing a mask if you're not able to socially distance, and really wearing a mask prevents others from being exposed to you. So this article, I wanted to share this with you because it really is the most comprehensive study out to date about COVID-19 transmission and wearing a mask. It's in a peer-reviewed journal. The Lancet is a British peer-reviewed medical journal. It's one of the oldest and best-known journals. And it looked at physical distancing, masks, and eye protection. And I'll just focus on masks. It did show that it was effective, that all 3 of these measures are effective. And this was published June 1st of this year, of course. It was enormous, and it is an observational study. So it took 172 studies, and it was international across 16 countries. It looked at transmission of these 3, of COVID-19, its sister coronavirus, SARS, and then MERS. And it looked at it in transmission in both a community and a healthcare setting. So it was a meta-analysis. It combined all of these studies, and the outcome was infection. And the result is that that a face mask could result in a large reduction in risk of infection. So they found a risk of infection wearing a mask was 3.1% versus 17.4% when not wearing a mask within households and among close contacts of cases. So it was a 17.4 down to a 3.1% reduction, which I find significant. This really competes with Charlie's complex graph, which I thought I'd show you all since you like complex graphs. So this is called a forest plot, and I'm really not going to go through it, but this is in the Lancet article, and these are all the different articles that they combined and did a meta-analysis for. And what we're looking at is this section. So this line right here, it's looking at these confidence intervals, and anything to the right of this line favors no face mask. That face masks do not work. To the left, it favors the efficacy of face masks. And you can see that all of these black dots and their confidence intervals line up on the left. So it really just did a composite view of everything that has been done, and then pulled them all together in that data point of 17.1 down to 3%. Apart from that, there aren't a lot, there really aren't, that is really the most significant study to date. And I really wanted to look at that closely. There's some other models that have come out, And I'll just mention a couple of them here. And this was a research article that was put out in Health Affairs ahead of print, community use of face masks, evidence of a natural experiment. And basically what it did is it looked at the natural experiment here in the US in 15 states, and it looked at policy. So 15 states that had face mask policies in place versus states that did not have it in place between April 8th and May 15th. And so the states that mandated face mask use in public were associated in a decline, and these are modeling estimates, a decline in daily COVID-19 growth rate, estimating 230,000 to 450,000, somewhere in that window period, cases averted using face masks, and face masks may have cut new cases by 50%. Again, not a randomized controlled trial. This is more of a modeling, looking at an experimental, but I do think that it's important information. And this is another modeling that the IHME is the Institute for Health Metrics and Evaluation at the University School of Washington. It's an independent global health research organization. And so they did some modeling predictions, and they said that if 95% of people wear masks in public, 18% fewer would die by October 15th. And they did modeling, they did it by state, and they did every single state, and they looked at Colorado and said there'd be approximately 125 in Colorado deaths averted if 95% of people wear face masks in public, and that was put out on June 24th. And then I just did, and anyone can go to the COVID-19, the epidemiologist website. I can send it to you later. I didn't include it here, but there is a website where you can play around with numbers. And this is just me entering the number of 50% mask use versus 90% mask use. And it looks at its correlation with hospital and ICU, predicting hospital and ICU numbers and deaths as well. And so all other variables, there's all the other variables of social distancing, all I changed was 50% mask use and 90% mask use. And I just thought it was interesting to look at, like, what does the impact of masks do? And this is from March. This is a year of model predicting from March to March 2021. And just visually, you see a significantly decreased number. The blue is non-ICU hospitalizations, the yellow are critical care ICU hospitalizations, and then the red are deaths. I thought that's really interesting, and it's kind of interesting just to go on the website and punch in your own numbers just to see the prediction of using masks in decreasing hospitalizations, ICU hospitalizations, and deaths. And again, this was actually shown in CDPHE. Epidemiologists showed this. I think I may have showed it to you about a month ago, that with 50% mask wearing, there's a prediction that we'll go over. This is our ICU critical care line. And then 65% masks reduces the counts over days, and then at 80%. So it's just more of a visual saying, yes, projected total hospitalizations and ICU needs will be decreased with mask wearing, and that there is a direct correlation between masks, hospitalizations, and deaths at this point. So distancing remains the most important risk reduction action we can take. Dr. Michael Osterholm from CIDRAP, who has been a very prominent voice throughout the pandemic. I believe that wearing a mask is the single most important step you can do to reduce your risk of transmission in places that you cannot socially distance. Socially distance really works, and if you can't do that, wearing a mask is the single most important step. And I also want to remind people, not only outside, because we'll be talking about mask wearing outside, but also to remember in cars and carpooling. And it's important to do all the 5 together. So the last slide that I have here, I wanted to look at is there any data on the time period? Right now we have a 10-minute time period. And really, I think the data are insufficient that look at, this is a quote from the CDC website, that the data are insufficient to precisely define the duration of time that constitutes a prolonged exposure. Recommendations vary in length of time exposure. However, symptoms and the type of interaction remain important. So the most important and critical part of transmission is how close are you, and did somebody do actions like cough in your face? Are you in a place that has less air movement? And all of these other variables, it's more of a common sense thing. So there's not going to be any science, I don't think, that says if you're within 5 or 10 or 15 minutes then you're okay. But if you step outside of that and you're at 11 minutes instead of 10, then you're not okay. I think we really have to use common sense here and look at the entire scenario. If you're riding a bike next to somebody and they're going the other direction, that is a much lower risk of transmission than if for a similar period of time you walk next to someone and they cough in your face. So I think looking at time is really not as important of a variable as looking at all of these other common sense type of interactions in terms of transmission. That is all I have. Thank you.
Karen, thank you very, very much, Dr. Levin. That was excellent. And I think the next item on the agenda, unless anyone has questions for Kimberly or, yeah, Tori?
Thanks so much. Thank you guys for all that data and information. Yeah, I don't know, maybe these go back to Charlie. 2 questions. The graph that was just shown about the recent transmission in the 20 to 29 range, did I miss that breakdown in our Pitkin County cases? What's the age breakdown in Pitkin County?
Josh, do you have that?
I know it's on our dashboard. I didn't have it on my slides. Looks like for 20 to 29-year-olds, we've got 22 cases.
How does that compare across the graph with other age demographics?
That's pretty comparable to 3 different other groups. So 30 to 39-year-olds had 24 cases, 50 to 59 is 22, and 60 to 69 is 24.
So almost a more even spread is maybe what I'd get out of that here. And then a quick question, and I know this is not something you can answer with data, but anecdotally, you know, those people that we are interviewing that are testing positive, are we identifying, are these people saying, you know, I have no idea where I might have caught this, or are these people that are like, you know, I did go to this party the other day and that might have been, are we getting any anecdotal information about the transmission in that sense? And I ask that in large part because of what we're looking at in the city of Aspen right now for strengthening our mask mandates and such. And I'm just wondering, you know, are we seeing targeted ideas about where transmission's happening, or is it just really out there blowing in the wind, so to speak?
So right now, about 40 to 45% of our cases are unknown source of exposure. So when we speak with them, we ask them a lot of questions to try to figure out where they may have been in the past 14 days and where they may have been infected. So we really do a thorough job trying to figure it out. And for 40 to 45% of the cases, they tell us, I have no idea. I don't know where I got sick. They try to come up with, you know, some thoughts about maybe, you know, where it may have been. But a lot of it's just assumption, they're guessing. And a lot of times they don't know. They say, I haven't been around anyone who's sick. I'm not sure where I got it. And we're seeing this trend in Garfield and Eagle as well. So we're seeing a significant amount of what we call community spread, meaning we don't know where it's coming from.
Thank you.
Greg?
Yeah, thank you. This is always a great presentation, great information. I take notes as fast as I can, and I'm trying to absorb as much as I can. I've had a question I'd love to bring up with regarding cases with, you know, as we're looking towards school reopening and protocols for reopening the schools with the school district. Do we have any information that you can share regarding any cases we've had with kids in this past? You know, I'm always looking at the older people. I'm always looking at 20 to 29 is the youngest group I've ever really paid any attention to here. And obviously it merits attention. What can we tell parents who are concerned about sending their kids back to school? Are we ready for that conversation?
Karen, I know you've been part of all the
Yeah, I'll
schools.
let Josh ask. I think,
Okay.
Greg, we actually have the answer to that question in the round robin around children's rates. As far as the schools go, we are actively working with the school district right now, as far as there's been some state guidance that has come out. There's also some local guidance that that we've been sharing with the school district, but I would say that might be a good conversation for our next Board of Health meeting to talk about the guidance and what indicators we might want to use to advise the school district. But ultimately, it's the school district's decision on what kind of tier they want to do, whether it's all in-person learning, a hybrid approach, or all online learning. But we're working with them closely on that.
Great, thank you. I've got more for the round robin then.
Thank you very much, Greg. Karen, I know that you're going to be presenting next.
Thanks, Marky. And Lindsay, if you can go ahead and bring up the slide deck. Thank you. So we've been working on a number of different things over the last week or so, and I just wanted to frame up for everyone because I think there was a little bit of a couple of different pieces in regard to our rates in our community, and then the request from CDPHE to put together a mitigation plan in relation to our variants. And as we were able to have further conversations with CDPHE over the last week or so, we did some deep dives into our data, and we're able to explore a little bit more with the data that they were pulling versus what we were pulling, and then realized that because we had always taken a more conservative approach and hadn't actually fully articulated out our variants. So our variants allowed us to have group sizes of 175, and we always maintain that at 50. We have been conservative and we did our slow roll, you know, as we started to open, we were slower to roll out openings as we moved through our Safer at Home order. And so, in fact, what CDPH realized was that that we are more restrictive. We're equal to or more restrictive than the state already. So the variance doesn't really play a role. And because we were so conservative, we didn't need to turn in a mitigation plan. However, we recognized that we wanted to have a mitigation plan, that we felt like this was really important due to the data that Charlie and Kim and Josh have just shared with you. So we've been working on a mitigation plan for really looking at the next 2 to 4 weeks. And the goal of the mitigation plan is to, and I'll share that with you, is to really look at a broad-based approach to how do we reduce the spread of the virus and how do we better contain it. And so it looks at everything from the box it in strategy to communication strategy to regional collaboration. So it's a pretty community-based approach to mitigation. With that, we were also working on an alert system to really think about if the mitigation plan is not effective, we might have to go back to some of the more stronger suppression strategies that we've had in the past. So if you remember the roadmap to opening, looking at that kind of strategy to roadmap to tightening up. And so this is like a contingency plan, but it's also a way to show data in a different way. So there's kind of 2 different levels to this coronameter that I'm sharing with you. One is to really have an alert system for the community, similar to a fire alert system, where we would really show, you know, here we are as a community, we're at low risk, moderate, high, or very high risk. The meter on there can move, so it's not always just stuck in the middle. It can really fluctuate. So the community can see, oh, wow, we're really getting close to the orange level. It's really at the high point of level 2. And we have some really robust indicators that we're using for this that we will not go into today, but the overarching themes of the indicators are around disease spread, hospital capacity, and disease control. And a lot of the data that you've been hearing about at the beginning of these meetings really feeds into those key indicators. So I wanted you to be aware that this is going to be a new way of showing information on our data dashboard. And it's a new way of thinking about sort of that suppression strategy if we had to go back to something really, really tightening up in our community. But the first goal is to really get this mitigation plan fully articulated and see how that takes us. And hopefully the fruits of that labor will allow us to not have to get into a tighter suppression strategy in which we might have to consider, you know, really reducing event sizes or something like that. Next slide. So this is sort of talking through what I've just said. We have that alert system, the coronameter that we'll have on the website. So that's a data, that's key indicators. And then when we look at the different stages of where we are as a community, if we're in a really low risk stage, the blue stage, we're really just advocating the 5 commitments to containment. And although that's always has seemed like a really simple message, it is a really critical message in light of what Dr. Levin just shared about with the mask and keeping social distancing, washing your hands, making sure you stay home when you're sick, and making sure you get tested if you're symptomatic. Like, those are super, super critical to the success of this in our community. The next stage is this mitigation plan that I'm going to be sharing with you, and specific control measures. So if you think about what Governor Polis just did, where he implemented the no call for alcohol after 10 o'clock, that's like a control measure strategy. He's not saying that restaurants have to close down. He's not saying that restaurants have to go back to 25% capacity. He's really doing this tinkering within the restaurant system to try to prevent spread that we have seen data show that it's happening with a younger adult population that might be less inclined to do social distancing as they start to drink more and more. So that's a control measure. We can also look at the sector-wide rollback, and this is something that, again, we want to stay at the top as much as we can in this pyramid. We don't really want to have to get to the sector-wide rollbacks, but what that would look like is if we saw, a lot of outbreaks in one sector. So we just saw, for example, maybe going along the same theme of the restaurants, if we just saw a lot of outbreaks happening in restaurants or inability, it's sort of a high risk business, that we would have to then say, okay, we're going to go back to 25% capacity, or we're going to close indoor seating and only have outdoor seating. There's a lot of different ways of looking at that, but that's really, we're hoping that the mitigation strategy will get us so that we don't have to get to that stage. And then the phased rollback is really, boy, that's like if we really are seeing major hospital surge and all of our indicators are just fully in the red, that's where we might have to look at, okay, we can't be in the safer at home in the great wide outdoors anymore. We're going to have to go back to the just safer at home phase. And if that doesn't work, we would have to go back to the stay at home. And I would imagine that would be happening at the state level, not necessarily locally. So there's different ways that we can approach trying to really tinker with those numbers and get our community spread in a place so that we all feel more comfortable. Next slide. So again, I'm just going to elevate on the blue level. It is the 5 commitments to containment. This is going to be throughout the pandemic. Even probably these are all good practices in general, even if we're not in a pandemic, but until we have a vaccine in place, this is going to be our normal. And I just think we have to get okay with that, to normalize and make wearing masks socially acceptable and just culturally what we do, regardless of our rules around it or our, even our thinking as we move forward. It should be, I have got my keys, I've got my cell phone, I got my mask, I leave my house and I'm ready to put it on. And then we just make that a part of how we live. We know that if kiddos have to wear masks in schools, as parents or as aunts or uncles or as friends, modeling that behavior for kids is really important right now, because that's going to be a critical part to being able to have schools operate in the way that they want to operate in the fall. So moving on to the next one. So we go from blue to that yellow, the mitigation plan, and this is what I want to really hone in on. And there's a lot of detail in here. We've been working pretty rigorously on this document. It's still, I would say, in a draft form, but just for you all to be aware of. So we do have a goal up at the top of really looking at slowing that disease transmission. And so you can read that. We have been at 253 cases per 100,000 people, and we want to get that down to 201 cases for 100,000 people, 36 cases over a rolling 2-period average. You all are familiar with our long-term goals, but we also stuck in there really schools being able to operate in the best model for learning. We know that's super critical right now, and what we do as a community impacts what the schools can do. If we have widespread community transmission, it's really hard for schools to be able to operate in the way that they want to. And right now schools really have a goal, I think, of getting kiddos back into in-person learning 5 days a week. We really want to look at our winter tourism industry and ensure that that can thrive and eventually get into that max vaccination plan. So what we're going to talk about today and what I'm going to show you today are some public health order revisions. We'll talk in detail about those. And then I just want you to be aware of all these other mitigation strategies that we have been working on, but really have had a pretty significant buildup around in the last few weeks because we've been able to get staffed up. And as you all are aware, we went into the pandemic in the public health department having 5 FTE. We had 3 vacancies, just normal vacancies at that time. Over the last 4 months, we have scaled up and onboarded 17 new FTE, which is a pretty significant thing to do for our little department in 4 months. So that was 3 previously vacant positions pre-COVID, and then 14 new employees to be able to address COVID-19 specifically. And you've met, Charlie and Josh as 2 of those employees that have come on with us to really help us with this response. So with that, all of this work's been going on, but we have a lot more emphasis on it because we have staff to be able to do this work now. So next slide. So this is how the mitigation plan reads, and it's a spreadsheet that I am not going to show you the details of, but I want you to understand the thinking behind it. So what we've decided is going up and coming up with strategies that really align with the different programs that we have in place. And of those, we have the public health order, which is one strategy. We have the sector liaisons, so that's working with the school district or working with restaurants or working with lodging. We have our consumer and employee protection program. We have our disease control and investigation team, which is the box it in strategy. We've got some communication and marketing, and we have some regional collaboration that we've been doing for a while. So there's a breakdown of those strategies, and then there's certain tasks underneath each of those strategies. And what we've done is we've really determined what we want the outcome to be. We've determined what the negative impacts of that strategy might be for the community. And then we've ranked them based on the need of that strategy. Does it increase distance? Because we know that that's such an important part of our overarching strategy. Does it reduce the number of contacts between people? Does it reduce contact duration between people? Are there physical protections? So that's like a mask or a plexiglass would be considered a physical protection. Is that strategy easily modifiable? Is it enforceable? And is it clear to the public? And then we've ranked these to see like what are the most important strategies based on our numbers. And so if it does serve that purpose, it's really clear to the public, it gets a 3. If it is not very clear to the public, it gets a 1. And so we just total up that score. So we've gone through and ranked a ton of different strategies to determine what we wanted to bring forth for our mitigation plan for the next 2 to 4 weeks. So we're going to dive into the public health order strategy right now because that's where we want to get some advice from the Board of Health right now. But I want you to be aware, and Lindsay, if you can just hyperlink on the mitigation plan title at the top. You can, and just scroll down a little bit so you can just see the amount of kind of thinking and reasoning that we've been putting into this document. And it's, as I said, still very much a work in progress, but we're really fleshing it out and should have it finalized by probably tomorrow. So and I'll go through the bigger buckets, but I just wanted you to be aware of what it actually looked like. So if you go back to that, thank you, Lindsay. Next slide. So this is really a reflection on what you've been hearing from Josh in particular, and where we're starting to see a lot of either outbreaks or a lot of disease transmission. And so we're really trying to be scalpel-like in our approach to the public health order. And again, instead of like closing down a whole sector or reducing capacity for a whole sector, let's look at where we're really seeing disease transmission and trying to address that more carefully and more in a scalpel-like way. So you can see here we have noted that informal group gatherings have been a place of transmission in our community. And a lot of times people are coming together, they may be coming together with friends that they think are safe because no one's symptomatic. And then all of a sudden we start to see some disease transmission in those group gatherings. And then they may bring those on into work. So that's been a source of recognition for us. Not wearing masks, as we know, can be a way to spread asymptomatically. And then we've talked a little bit about, what are some strategies around addressing visitors in our community, and know that Pitkin County, although we can do a lot of things locally, really the best approach, especially with visitors, is more on a statewide level. So we're going to give you an idea around that today. So next slide. So what we really want to see is wearing masks. There's Brent at the very top in the I Wear a Mask campaign. Again, thank you all for participating. This has been really cool to watch that unfold. We really want to encourage small groupings. People staying in their social bubbles is really important right now. So your household or people you normally interact with, you don't want to increase your interactions with new folks right now. That really does not keep the social bubbles intact, and that's a really critical part to reducing spread of disease right now. And then finally, we know that statewide quarantines are such as what New York State is doing, or Maine or Alaska, are probably more effective than a local quarantine effort. So we would like to propose a required change to the public health order in regard to mask. One is just to go ahead and align that order with the state order that just came out with Governor Polis's executive order. And I don't know, Larissa or Jordana, if you want to talk to this very quickly, the couple slides you have in here.
Yes, thank you, Karen. Good afternoon, everybody. I probably am meeting most of you for the first time, but I am a relatively new member to the team. My name is Larissa Dandino. So kicking off some of the changes to the public health order are, of course, some of the required changes in accordance with the state mask order that recently was released. And that will include our face covering requirements expanding to not only while using public transport or non-personal transportation services, but also when waiting to use those services. And in addition to the indoor public spaces such as grocery stores, retail businesses, restaurants while being seated, that is currently required, mask requirements will also expand to include all offices, lobbies, elevators, indoor businesses, common areas, and gyms, except while using an indoor pool, and also when receiving a personal service such as a massage parlor or hair salon. And then finally, businesses are required to post signs that at entrances that instruct customers to wear a mask when entering the business, but also moving around inside the business. And they must refuse service to individuals not wearing masks, as well as refuse entry to individuals not wearing masks. Next slide. So thank you, Dr. Levin, for presenting some of that science that you found. I had reviewed some of the same type of research and kind of have spent some time digging a little bit more into it. And so I just wanted to briefly share some of the evidence for universal masking. And when we are talking about universal masking, meaning that everyone is required to wear a mask at all times, whether indoors or outdoors, especially when that 6 feet cannot be maintained. So the first study I wanted to share was one conducted in the Hong Kong Special Administrative Region, where they observed actually 11 COVID clusters in recreational mask off settings compared to only 3 in workplace mask on settings. The next study was a literature review that suggested that universal adoption of masks when out in public in combination with other mitigation strategies could successfully reduce the effective R to below 1.0, which as we know is the basic reproduction number, and being below that 1.0 could actually stop the community spread. Another study which represents the image there that you see on the right hand of the screen, was actually recently done at the end of June, found that uncovered emulated coughs were actually able to travel up to 12 feet in around 50 seconds, which is twice the currently recommended 6 feet distancing guideline. But this study was conducted in an indoor environment, but still provides compelling evidence that on the benefit of face coverings in reducing airborne transmission. And the following study, lastly, was a numerical study that found that the influence of wind might actually allow airborne transmission to travel at least 10 feet. And so what we do know, as like Dr. Levin had mentioned, is that masks are very effective in reducing the risk of transmission in an indoor environment. And although there is limited research comparing indoor transmission with outdoor transmission, the research that does exist suggests that one of our best methods of protection are face coverings in all public settings, especially when a 6 feet distance cannot be maintained. And as she had mentioned, Dr. Levin, that the CDC says that transmission is more likely when 6 feet distance cannot be maintained, and that transmission is more likely when someone has a close contact, which is defined as spending 15 minutes or more within 6 feet of an infected person. And we know that close contact in confined spaces raises the risk, but it's not clear how much the risk declines if close contact is more fleeting. So if you're walking through a rural area where a 6 feet distance cannot be maintained, then a mask may not be necessary, but you might consider wearing one if you are in a more outdoor setting, like a public park where there's barbecues and picnics going on, where it's a lot harder to avoid contact with potential asymptomatic cases. And so the CDC's actually, their previous exposure time for a close contact was 10 minutes. And even, again, thank you, Dr. Levin, because she shared that quote from the CDC that there really is little evidence to precisely define a prolonged exposure. And so we really need to rely on the best available evidence rather than awaiting stronger evidence when devising these policies that really can potentially save human lives. And next slide, Lindsay. So finally, what we are recommending is to remove the 10-minute time frame from the face covering requirements, which would help to not only really strengthen the requirement, but also simplify the messaging. The 6 feet distancing guideline has been ingrained in people from the beginning through numerous sources, including our 5 commitments of containment that Karen mentioned a little bit ago. And so if we're trying to relay a consistent message and prevent the spread, then normalizing the behavior of wearing masks in all public spaces, both indoors and outdoors, regardless of that exposure time, may prove to be beneficial. So as you see on the slide, we are basically just proposing to remove that last statement of for more than 10 minutes. Thank you.
Karen, do we want to discuss each item as we go through? Okay, welcome to the team, Larissa.
Thank you. Thank you. Glad to be here.
I would like the board to weigh in on the 10-minute, and let's see if we can come to some consensus or support for the recommendation of staff. Tori?
Thank you. I and City Council are very supportive of removal of the 10-minute clause as was just shown. We'll be discussing that in the city's order as well next week, and I would anticipate that we're moving that direction. The question that I do have on the last slide was about the still including the members of the same household. It's difficult because, you know, we're trying to be, in so many cases here, we have tried to be so accommodating with what we need from the public. But that same household, it makes it difficult for us for enforcement, but it also makes it difficult when you're downtown, because you don't know if people are from the same actual household, and people are utilizing that part of that language as they see fit. So it's not members of the same household that will be walking together without their masks on, and that gives them the ability to do that when they are not truly members of the same household. So I do question, I would like the board's input on some way of better language for that. I just feel that it makes enforcement difficult, and on the streets when you see it, you have no idea if that's the case or not. What we have downtown Aspen right now is density. So when we talk about people being with same household members and not wearing a mask, if they're walking down the mall and they're like, well, I'm walking with my friend who's staying with us, same household. Yeah, but you're walking by other people that aren't from your same household. So we're having a real difficulty meshing the two ideas that you should not be in contact of 6 feet or less, along with that ability to drop your mask because you're with somebody of the same household. And that's some of the reasoning that we are looking at and considering going to that mandated mask zone. So we're really looking to kind of sync up as best we can. And we want Pitkin County and the Board of Health to support the measures that really are effective. And I'm just wondering about that language as well.
Okay, yes, Jordana?
Can I jump in and address that for Tori? So I think that's a really great point, Tori, and I think it gets to the fact that we're trying to create different laws and orders and rules that make sense for different parts of the county. So exactly as you said, rural Pitkin County, where you might have folks of the same household going out for a hike together on a trail where no one else is around, they're going to be within 6 feet of each other. If they pass another group, they're going to need to mask up. But the idea is that if they're out there in rural spaces, that it's really different than being in downtown Aspen. And so we as the Public Health Department really support the idea and what City Council is working on in creating a mask zone, which we've heard from our law enforcement partners is that if any of this enforcement is going to happen, it needs to be extremely clear when people are complying and not complying. So we definitely support that. Larissa is working on a statement to be able to come to your second reading and explain to the public that that is considered alignment, and we support the city in doing that. But for considering the differences that exist in all of Pitkin County, we wanted to be able to also put something into the public health order that people felt like they could also follow and made sense to them.
Thank you very much.
I appreciate that. I do think that you would probably agree, though, that makes it difficult in the downtown Aspen area. That provision makes it difficult for us for not just enforcement but compliance as well. Like I say, you do have those people that are looking for opportunity not to wear a mask, and if two folks are standing there that should have masks on, we don't have the ability to walk up and say, excuse me, do you guys live in the same household? That is another layer that makes it difficult for us to get compliance, not just enforcement, but get compliance downtown.
Tori, I applaud the efforts of Aspen City Council looking at the mask zone. I've been spending some time here on our mall and down in Base Village. I think my council, and we haven't talked about it, would be supportive of whenever you hit a shopping area here in Snowmass Village, you got to mask up.
Thank you, Mark.
So, yeah, it's really, I see so many visitors here, and I think it's wonderful. We have a lot of wonderful guests that have come. I would say about 90% do comply, but it's that 10% that I'm very concerned about. And back to your point of, are you guys in the same household? Those types of questions. I think if you had the mask-free zone, and perhaps we do, I see Billy Manson's on, and if we did that in terms of the large areas for shopping and eating here in Snowmass, I think we would get some support accordingly. Greg?
I really appreciate that. If we can eliminate some of the gray areas, I was thinking when you were speaking, Marky, that it's not about whether it's a shopping zone or a restaurant zone, but it's an area where you have public congestion. And if we can define how many people makes public congestion, we could just say, if you're ever in an area where there are other people, put your mask on. And maybe it's as simple as that. And it's not about 10 minutes. It's not about 6 feet. It's because those are really, what are those? Those are rules of thumb, which we came up with very thoughtfully, but really they're rules of thumb. If your viral load happens to be much higher, you might be much more dangerous at 10 feet than someone else who has a low viral load at 3 feet. So let's just get rid of that and say, if you're around other people, wear your mask. And I don't know if I can make it any simpler than that. And there may be downsides to it, but I would advocate for that. And I think that seems like that might be where the city's going and where snow masks could go. It's like you're out sitting on the grass watching the movie, the drive-in movie in snow mask. You're not near a restaurant. You're not in a shopping center, but put your damn mask on. I can't help but think that we need to simplify it to that point and really put that message out. That way, wherever you're around other people, you wear your mask, and there really is no gray area. It doesn't matter if you're living together or you're faking it. I can't think of a simpler way. Thanks.
Thank you, Greg. Other members of the board? Some comments? Jeannie, I see your hand up.
I agree. I think everyone should just get used to having a mask in their pocket, whether they're riding a bike or going for a trail run, and just pulling it out when they see someone else, because that's the new normal. We should get used to it.
Thanks. To pile on what Jeannie said, is maybe part of the campaign is have your mask ready and be prepared to put it on. I just made it more complicated, but it's have it available and put it on. And maybe someone suggested maybe even have it visible so you're not freaking out the other people around you who think that you may not have one.
I think what you said is the right thing. I mean, there's so much confusion, and to have anybody, mathematically computing anything is probably a mistake. The fact is, if you're around others, you should be wearing a mask. End of story. I think that's a good message.
Patty?
Yeah, I'm in agreement with Greg. I just got back from California where there's total disregard for distancing and mask wearing. The crowds were amazing. The restaurants were doing a good job. The airlines did a great job. But the people down on the piers and stuff, it was kind of appalling to me. So I came back with the theory of let's do 2 weeks if everybody wears a mask and see where our numbers go, which we know our numbers will come down. So however we want to do it, I support what Greg just said. I think the rest of the Board of County Commissioners would be supportive of that. Let's make it as simple for enforcement reasons and for compliance reasons. So when you're out and about, you put it, and the other thing too, which I think maybe Greg and I did talk about, was have it visible. Some people have it tucked in their backpacks or in their purses, and then they're fumbling. It needs to be, so if you're coming along and you're out, say, on a trail and there's nobody around you, but you see a crowd coming, it's right there. It's not a matter of having to take time while everybody's passing you to find your mask. And I think that also makes others feel more comfortable. So I'm supportive of Greg's position on those issues. Thank you.
And to your point, California, at least in Santa Monica, the distance is now 30 feet. But it goes to public responsibility and lack of it, I guess.
Yeah, Greg?
I just wanted to point out that we're thinking now about people we see in public who aren't wearing a mask, who are flagrant. I had a bike ride this morning with a Glenwood Springs councilman, Rick Voorhees, and he said that they're seeing a pattern at the Walmarts and the shopping centers down in Garfield County where people will wear their mask in to get through the door, and then they take it off in defiance. There's a defiant movement there, which is really kind of disturbing. And I think my point that I wanted to get to was, if we have certain areas, like I'm wondering if we could actually in our messaging mention that these are the areas where we have the highest rates of infection. And if Texas is winning do we try to find some thought leaders and people from Texas who might model behavior for Texans? Can we say, hey, you know, Texas is winning the COVID-19 transmission spread here. See what you can do about it, folks. See if we can get people to really be aware of what it is they're doing. I'm just wondering, thinking ahead on messaging or a campaign or something, just so people know this is where it's coming from. It's not just outsiders; it's everyone. But maybe they're winning the race.
Okay, we need to take the one thing at a time here. And I'm looking to Karen. Were you able to capture the sentiment of the board?
I think a firm statement of, you know, we put a proposal out there with the language. I'm hearing a little bit of a difference. So I think we just need to hear very clearly from the board what the language should be adjusted to. Are people in agreement to what we had? I think there may be some issues around, I'm not entirely sure, I guess. So
can you put the language up again for us?
Okay. Face coverings are required to be worn outside whenever there is a risk of being within 6 feet of another person who is not of the same household. And what I think I'm hearing the board say, face coverings are required to be worn outside whenever there is a risk of being, no, just face coverings are required to be worn outside if the probability of closeness or crowds let's see, whenever there is risk. How about worn outside whenever there is a risk of being exposed?
Coming into contact?
Coming into contact, that would work.
Well, yeah, then that's physical contact versus what kind of contact are we thinking? If there's a risk of whenever, how about required to be worn outside when in a public situation involving others, something like that, or in public among others. Maybe it's as simple as that.
How
That's
about just
what we're getting to, right?
Yeah.
it's
Brent?
simple. How about just a statement? It's simple. When you're near others, wear a mask. I think the others, I think we can get into, the actual logistics and the semantics of how to say that. But basically what we're saying, right? If you're near others, wear a mask. And I'm a big believer in simple mantras, not giving people any kind of, or including myself, any kind of wiggle room to interpret something. But
I would propose we add masks must be displayed also. If you're outside, you're around others, you're outside 6 feet, you've got your mask available and it's obvious. If you get closer within, whether it's 6 feet or proximate, you wear your mask.
Okay, I'm going to let the staff
Thank you.
agitate on the right language. I think, Karen, do you have the spirit of what we're talking about?
I have the spirit of what we're talking about, yes.
Okay, I want to make one other suggestion. Jeannie, I'll call you. I'll be back with you in a second. The other day, I was seeing my hairdresser, and because we have to get our hair dyed every once in a while. But anyway, one of the things she said is, why is it that the Public Health Department not have a little column right on the front page of the Aspen Times and the Aspen News as to the number of, like that, the COVID-19, but I'm saying the chronometer might be a very interesting for the public. The minute they pick up the paper, they see where we are and what our number of case counts are.
Dr.
Tom?
Levin's group brought that up yesterday, so we have that on our
Yeah.
radar screen as well.
Marky, I completely agree with you. And I think a quick visual on a daily basis for the masses of people would be a great idea. And I like the work on the chronometer that's been done so far.
Patty?
Grassroots has also offered us the running, the banners, whatever we want to get the word out there. So anything we can craft that fits within their parameters on their channel when they're running it, they have been more than, every time I see them in our meetings, they're like, let us know, let us know. So that's another great contact for us to utilize.
Yeah, and I do see some reporters that are listening to the meeting, so if they can take it back to their respective newspapers, and let's see if we can get that started over the next week or so. Jeannie, you did have your hand up. I apologize for not calling you back.
No worries. I just thought the new proposed wording was quite clear about 6 feet, but I just wanted, we could keep that and then add what Greg was saying about having a mask, you know, at the ready. So just, I don't want any confusion about someone saying you're within 10 feet, or we just keep it as clear as possible. I think that's best.
Brent?
Yeah,
Thank
I
you.
think there's also, assuming I'm going out here, I'm on my iPhone, my computer quit on me, but you know, I also see, and I could be maybe imagining this, but there's a certain complacency out there, especially among younger people. I don't even know, maybe I don't assign it to a group, but there's a certain complacency and maybe even a lack of knowledge. What I don't see very often is, except when I hear Fauci speak, and that is, we're losing this battle. We're in a war, and right now, we don't know what statistics to pay attention to. But we know we're sort of losing this thing for a period of time. And to me, I would appreciate seeing in the newspaper or somewhere some sobering statement, you know, that we need to get tougher, not more relaxed. This is going to be more tough later. We don't even know what this winter is going to be like, and we need to harden our resolve, and as opposed to soft words. But that's just my thinking.
Thank you.
Yeah.
Okay, I don't see any hands going up. Karen, did you want to run? Oh, Tori, did you have something to say?
I mean, just to say the last thing, that I hope that this conversation gets followed through in the public health order. You know, again, we're talking about compliance here, and while I'm happy as the city of Aspen to continue to do things that are in the best interest of our downtown, as we all have been talking about, the regionalism that it's going to take in order to really win over this virus is something that we all need to be doing. So when I think of the city of Aspen putting in the mask zone itself, it just makes me think, well, you know, we've seen that a number of transmission is coming up valley. I mean, we need to be unified in this. So I would advocate again for removing the family member language. I advocate for whatever the strongest language is to say that you must be wearing a mask when you are anywhere near somebody. And I don't even like the word near, because that's subjective. So if you can see another person, you should put up your mask. I don't know how we get there, but I hope that we are moving towards a public health order that is strong in this language. We have done, like I said, and I'll say it last time, and then I'll stop on this. You know, we've been so accommodating. You know, we started with, here, we're going to give you a mask. Then we said, oh, you got to wear a mask when you go into a business. And we've kept making these allotments and allowances. And I agree with Brent. We've got to do something that is strong of nature and really get a grip on this. I love what Patty said about, if you got 90% people wearing masks in 2 weeks, you would see a decrease in our transmission numbers. So whatever we can do, however we can do it, I just want to advocate from the city of Aspen side that we are for the Board of Health, the county commissioners, and the county to be moving forward in a strong direction here with us. And that's my hope. So thank you so much. And I'm looking forward to that language.
Kim and then Tom.
Yeah, I think it's a great discussion about how do you put out something that's so clear. The only thing that I worry about is that some open to interpretation. So the word near or close. And so in a way, I am in alignment with what Jeannie said. Let's keep it how it is, but take out the time limit so that there is evidence that 6 feet or 2 meters, there's been some studies done. We all know that it can be further than that, but in general, some type of a guideline, but take out the 10 minutes, to me makes the most sense. Just my pitch. I just wouldn't want any open to interpretation where somebody's arguing with the police saying, well, my interpretation of near was this, and someone and the Board of Health says this.
Okay, thank you. Tom? Tom, you had your hand up.
Tom needs to unmute.
Tom, you need to unmute. I've got every darn phone going off in this house, every iPhone. Karen, can you go ahead with the next point? I think you've captured our thoughts and our comments in terms of public health order. What's the next item there?
Thank you. Lindsay, can you pull up the deck again, please?
Well done. Thank you for bringing that up, Karen.
So the second piece that we wanted to consider is looking at, and this is, again, we're trying to be scalpel-like. So we're looking at what we're seeing as far as disease transmission, and knowing that it has been a lot of kind of these informal group gatherings, non-commercial gatherings. So things that are not necessarily permitted, not necessarily in association with a event, a scheduled event, but that folks are coming together. And what we've been hearing with the contact tracing is that people just feel, they feel really safe with their friends because they're like, well, my friend doesn't appear sick, and I trust them. And so they're getting together, and they're getting together in close, maybe sitting around a campfire and not necessarily masking up and not keeping social distancing in place. And so really, again, trying to be scalpel-like in our approach, and not, saying that all events need to go down to 10 people. But what we are proposing is that informal group size does go from 50, which it currently is, down to 10 people. And so the language would read as on the right, that we were really limiting that from 50 to 10 people, recognizing that this is, is all kind of, even in the discussion with the mask order, some of these pieces are fairly hard to enforce, but it is making a statement, and it is addressing something that we feel like is where we're seeing some disease transmission. And it's something we can do some messaging around once, if the board agrees that this is the right direction to go. It is really helping our community to better understand about staying in those small social bubbles, not feeling like just because someone isn't coughing, it doesn't mean that they don't have COVID-19. They just might be asymptomatic, and that you can assume that, assume that someone in your close contact circle might actually have COVID-19, and to kind of act appropriately and act accordingly because of that. So I'll leave it at that. There's not that much difference there. It's simplified the language a little bit too.
Markey?
Yep, Patty?
Yeah, I don't have a problem with simplifying the number or reducing the number. I'm just concerned about going from 50 to 10, because you have to remember some families have more than 10 members. So that would keep a separation of families. So I don't know if 25 or 20 might be more reasonable. I think I definitely think we need to address group gatherings. We see them, that's what I hear from my constituents on a continuous basis. The people up at the Molly Gibson Park, the kids at Wagner Park or Heron Park, the kids, anybody younger than my age are kids. And I really like the simplified language in the proposed. I just think that the number might really cause some more issues for us that we may not need to be dealing with. So I'm thinking maybe 20 might, just so we can incorporate families.
Well, perhaps what we do, Patty, is could we add within the proposed language that no more than 10 individuals that are not part of the same family?
I think we get back into the same thing about not wearing a mask with when you have family members, because everybody on the block would suddenly become family. So I
Patty,
think just,
I just want to clarify that the same language that's in the current language, the current public health order would hold, in that nothing in this order prohibits the gathering of members of the same household.
okay.
That's true.
So maybe we should add that in there so people don't have to search for it.
Sure.
Thank you, Jordana.
Okay, good. Thank you very much, Jordana. Tori.
Can I get some clarification on this? Informal gathering sizes, what's the nature of the word of informal? I'm just unclear. Gatherings hosted by a business, other size provisions. I'm just wondering, where does this line sit? I get that you're saying a party in the park cannot happen. But you could, and tables of 8 are only allowed at restaurants, but could a restaurant host a party for 20 with this language? I'm just unclear on where this
Tori,
line says it.
I'm happy to answer that. So the informal gatherings are gatherings that aren't already addressed in the public health order and that don't require a permit. So if you require a permit, you're going to need to fill out an event safety plan, and you're already going through a formalized process. If you're a restaurant that is hosting, some kind of gathering, they already have filled out their business safety plan and can accommodate a larger group, but no informal gathering. So if you don't have a permit, you don't have a business license, if you haven't filled out a business safety plan or an event safety plan as a part of a different permitting process, it would not be permitted.
Okay. Do I hear any other comments? Is there kind of a thumbs up, guys, if you're all comfortable with the language?
Just the last bit on that. It sounds as if we removed informal from that, the bold-faced headline on that, it would still have the same weight and have the same effect. Limits on gathering sizes for individuals or gathering sizes. I think if you're an individual, you're not technically gathering, right? You could say limits on gathering sizes could be similar. I don't want to parse it, but I'm just thinking, as Tori may have pointed out, we don't really need informal here, do we? Certainly it's okay to keep it, but if we're trying to simplify, limits on gathering sizes just takes away the ambiguity.
I don't know, because I'm thinking about, then you go to the next sentence, and gatherings hosted by a business require a permit. So if I have a permit, then any other gathering would be informal. So reverse logic.
Okay, I'll let that stand then. Forget it.
Any other comments? Karen, were you able to capture that we're very supportive of staff's recommendation?
Yep, got that. Thank you.
Okay, let's move on to the next.
Lindsay, if you can bring us a deck one more time, or maybe 2 more times. All right, this is the final piece that we just wanted to discuss, and it's only because it's come up, I think, in many different forums and fashions, and we wanted, and Charlie alluded to this too, but we know that there's been discussion about, 14-day quarantine, perhaps for visitors or residents returning back into our community, and we really do believe, as I mentioned before, that those kinds of traveler restrictions work best at the state level. And we would love to get support from the Board of Health to work with other rural resort communities that might have a similar interest in this, other municipalities, if the town of Snowmass Village or city of Aspen or Basalt would like to think about this as well, to really advocate for a statewide policy, looking at restrictions on visitors traveling to Colorado with symptoms the last 10 days. So for that sort of a self-diagnostic, please don't come if you are sick. And then also to consider hotspot locations, which unfortunately tend to just continue to grow as we see more transmission throughout the country. So that is what New York State has done. And we think this strategy would be best implemented at the state level, and to have some advocacy toward the governor's office in trying to ask for this.
Okay, what? Yeah, Patty?
Yeah, I sit on the executive board for Northwest Colorado Council of Governments. I'm actually vice chairing it. So Karen, maybe next week you and I, maybe John, can put together something, and I would be glad to send it over and get it in the mix for Northwest COG. Snowmass is also, Alyssa's very involved. Basalt, sometimes Aspen we don't see Skippy very often, but I think we can rally support from our side to try and get the other rural resort region, municipalities and counties involved in this, and see if we can get a show of support and move it forward.
Thanks, Patty. We'll put together something for you then.
Yeah, just let me know and I can meet with you and John.
Okay.
Yeah, I think the sooner that we get on trying to get this thing under control, the better we will be in shape to go into the winter season. We've got a lot of folks up here from Texas and Florida, so it makes me very nervous. So let's try to clamp it down. And Patty and Karen, thank you very much for your willingness to take that to Northwest COG. Tori's hand is up.
Thank you. Yeah, in the same sense, I would love to get this to CAST, the Colorado Association of Ski Towns, and have them consider this for support as well. It does bring up one question that I have, though. Have we considered having people signing letters of agreement, or self-screening? Say somebody checks into their hotel here, are they being asked about their symptoms or asymptomatic, or if they've been in contact? Are we doing any kind of visitor screening that's coming in currently? Is that something that we've discussed? Is that something that would be possible to implement in any way?
It's a good question. I'll defer to Kara, who's been working with the businesses and lodges. I do know that one thing that we've seen as a good model in Alaska and in Maine is that they require anybody coming to their lodges to actually sign a form that they've read the public health order, or they've read the isolation. Please isolate if you're sick 10 days before you come, or sorry, please isolate before you come, not if you're sick. And so they do embed that in their reservations process. And I think there's some value in doing something like that here locally. And Kara, I know you've been tossing that idea around, so I might have you pitch in a little bit, but I don't know about the first question, Tori. So I'll let Kara address that first. Yeah.
Yeah, Tori, I think it's a great idea. It's something that we're working with the communications team and just haven't had the chance to do that outreach yet to the lodging community, but it's definitely the lodging community is willing to be a partner. And we're working on trying to get that set up.
I appreciate that. It'd be the same thing I would say. I know resources are part of this, but same thing out at the airports, both airports that we have operating here. I would love if people that were deplaning and arriving in Aspen were greeted by somebody that was there to say, hey, please read this, sign this, or at least make it aware. I know that there's been some good work out at the commercial side out there at the airport, but I think there's probably more that we could do. Anyway, I'm just really advocating for any way that we can welcome our visitors into a safe community by knowing that they understand their responsibilities as they enter our safe community.
And I suggest getting ACRA on board. They're a great way to disseminate this information to lodges. So I think Kara's probably already been working with ACRA, but they've been very helpful.
Thank you very much.
And Tori, are you our connection to CAST? Is that, would we work with you on that, or?
Absolutely, I can get it to you, Cass.
Thank you.
I'll be glad to help you. I'll be glad to help you, Tori, on that one too.
Thank you.
Okay, next item, Karen.
So I'm going to go through these very quickly. Again, I wanted you to have a full scope of the full mitigation plan. So we just went through one little section of it, which is the modifying of the public health order. These are all things that we, as I mentioned, we either have in the works and we're building out, or we're strengthening, or we're expanding. But I just want you to all be aware that this, guidance to different employers is really an important part of our strategy. And we have a sector group that, and Larissa that you just met today is now a part of that group. Kara and Jordana are, Bob Schultz, there's a number of different folks. So we're building out that team and really trying to provide some real support for these different sectors, especially sectors, as Josh mentioned, that might have case data that are indicating challenges. And right now that is everything from, as he mentioned, the housekeeping industry to construction. And so really, if there's some special emphasis that we need to put on sectors that are having maybe more disease transmission within their employees. Next slide. So we have the Consumer and Employee Protection Program that we've been building out, and really that Brian is leading that. And we have hired our first team member and hopefully have another team member coming on next week. So that will be built out with 3 folks. That's in complement to the program that the city of Aspen is building out as well, and really looking at how do we help educate businesses, help them to come into compliance. And then if we have to go into the enforcement realm, that's that program. So building that further. Next slide. We have the box it in strategy that you are familiar with. We're doing some really targeted work around that, a lot of data analysis, as you've seen, a lot of quality improvement work with that, and really trying to figure out how to make that program best run effectively and efficiently. And that does include, as you were mentioning, Tori, a lot of regional partnership that we have going on right now with Eagle and Garfield. So that's one place we're putting a lot of energy into our regional partnerships. But here are some of the different places that we're addressing, and we have strategies underneath each of those bulleted points. Next slide. We are looking at communications and marketing, and really having a particular focus with the Hispanic Latinx community, ensuring that anything we're putting out is culturally competent and culturally specific. And then really having some specific deliverables that we can help support law enforcement, so that we can do trainings with them, or different kinds of collateral that we can share with them to help them do their jobs when they feel like they might want to take a compliance action or an enforcement action. And then finally, we have a ton of partners that we meet with probably sometimes multiple times in a week, but these are many of the partners that we work with at least weekly. We have meetings with almost all of these folks. So we are really trying to engage our partners in different ways around communications in particular. Next slide. And then we do have this regional collaboration. We're looking at a communication and marketing campaign for the whole region to really influence behavior change. Communications and public health, one thing is to educate, the other thing is actually to use communications to try to shift cultural norms and change behaviors. And that's a lot harder to do than just educating folks. And so we're looking at potentially bringing in some funding to do more behavior change kinds of communications that we think might be more effective in the long run. Education is always a critical part, but that's just one piece of the pie. We're also looking at mitigation around a regional testing strategy. As you saw with Josh's data, that we're having really slow turnaround times. That's going to impact our ability to do the box-it-in strategy effectively. So we're working with the 3 regional hospitals as well as the 3 regional public health departments to get a regional testing strategy built out. And then we're also talking about a regional disease investigation team that would be composed of Eagle, Garfield, and Pitkin epidemiologists and contact tracers, so that we can really address the Roaring Fork Valley and some of the challenges we've had within multi-jurisdictional investigations. We also want to influence on the state level, so that's in regard to what we just talked about. How do we get our rural resort partners, or at least our regional partners, to advocate for specific things at the state level? If the state had a really strong containment policy, or a statewide testing strategy or containment strategy, a statewide communication strategy, those are going to actually impact us more, because we know we're all interconnected with both the region and the state and the nation and the globe. So the more we can have at the state level, the better. So we're really pushing from a regional perspective, and we leverage our voices as best we can to influence the state decisions. Next slide. Okay, so that was it. That's the super overview of the mitigation plan. We'll come back to you on how that's going. And again, that is reflective of 2 to 4 weeks. We're really hoping that all of that work will make a difference in what we're seeing with our disease transmission. But ultimately, if we get to a point where we have to look at more kind of suppression strategies, we'll bring those back to you as well. I'm going to turn this over now, because the chronometer is the way to really look at more of that suppression strategy. But again, this is very high level. We're just going to share a little bit of an overview with you about this.
Okay, so, we introduced this a while ago, but the chronometer is going to, take into account a number of different variables that'll give everyone in the public a situational awareness of what our alert level is. And so you'll notice that, it talks about, it's really tied to our comfortable, cautious, and concerned levels, which come out of a matrix that has a lot of variables or indicators underneath that. Next slide. So right now, this is just a summary of where we are right now in our current level, and the things that are allowed or restricted or advised. And with each level, it's tied to some level, a number of things, but we're able to look not just at moving back phase to phase, but looking at individual sectors or individual businesses even that are having difficulty, and addressing those first. Next slide. And the key indicators that we're going to be looking at, that are within each of these, are tied to disease spread in general, the healthcare system, and disease control. And these are numbers that are things that you've seen before. You've seen Dr. Levin talk earlier about the ABH matrix. That's really the healthcare system capacity. So just within that, to use it as an example, we are monitoring how many people are in the ICU, how many people are out sick that are essential healthcare workers, what kind of testing volume is the hospital doing. All of those things will weigh into hospital or healthcare system capacity. And those will have an effect on how the meter moves. Go ahead, next slide. So to give you an example, here under disease burden, we're going to be looking at cases, a number of new cases in 14 days. We're looking at the positivity rate of testing over the past 14 days. So these are just two of the indicators of a larger list under disease spread. Next slide. The same thing under healthcare capacity for the hospital. All of these different indicators are going to be looked at to determine what the healthcare capacity is using the ABH matrix. Next slide. And then finally, under disease control, we're looking at indicators like, do we have sufficient testing? And looking at the 14-day rolling average of daily tests performed, the timeliness of investigations. Josh gave you some figures there that right now it's taking from symptom to actually identifying a case of 8.8 days. If most people become infectious 2 days before they show symptoms. So that means they're already out there potentially spreading the disease to another contact. If we're not able to identify those people who now will show symptoms within the next 5 days, you know, that's even inside of the 8 days. There could be second generation, even third generation transmission if things are taking that long to happen. So we need to shorten that interval. And that's one of the measures that we're going to be looking at, is how do we shorten that interval from symptoms to actually starting a case investigation. Next slide. So I'm going to turn this over to Jordana, I think, who's going to talk about control measures.
Oh, good to know.
All right.
I'm going to talk about control measures.
Hopefully.
But
Is it Jordana or Kara? I'm not sure.
I can talk. It might have actually been Justine, but I can talk, and Jordana, feel free to jump in. So the control measures, as if you all remember the pyramid at the very beginning, this is where we can start to take in those specific approaches within sectors that we see and implement those based on the data and what the indicators are telling us. So really, I think what's important for the community to know, and all of us, and I think it was Larissa might have even said it earlier, is that we're all learning through this process. So initially when we opened, we had the roadmap to reopening, but we ended up doing more of this rolling incremental approach. We really want to try and use that approach if we need to pull things back. So there's really kind of three key questions that are those control measures that can be implemented as we look at if there are things that need to be rolled back. And it's really going to be, to what Karen said initially, are there data-driven evidence for sector-specific changes, such as 10 p.m. liquor sales at restaurants is a perfect example. So we can continue to look and identify if there's anything there that could change in the guidances or even in the public health orders. Then the second is, you know, going back to our high-risk chart. Where are those more high-risk activities? And where are those clusters there? And maybe are there changes that we can make within those elements to bring those indicators back into a comfortable zone for our community? So, you know, it might be some tweaks to the way that the sector-specific guidance is working, and again, working within those high-risk activities to identify different ways and changes. And then lastly, if the spread remains prevalent, is using that last effort, which is the phase rollbacks kind of that roadmap continuum that we're used to seeing. And so we can just look and think of all the different activities and sectors are really kind of continued on that high risk or that risk continuum that we've been using. Next slide. Yeah. So this just takes that risk that risk matrix we've been using and kind of starts to align it a little bit more with our coronameter. So it thinks of what are those high risk activities. And for example, we know all those in the red, those are not really allowed right now. Right now, we're also seeing, here's a lot of the things in the moderate risk activity zone, and we're going to keep monitoring those and where there are different actions that can be taken within those sectors based again on the data and the indicators that we're seeing and different new ideas coming up that we could start to implement to maintain the spread and reduce the spread. And then kind of where are those other activities that remain low risk at right now. Next slide. So that's really the summary of the control measures and how we would look to, again, use the surgical and incremental approach and really use this full phase rollback as the last means, and instead be working specifically, again, within the sectors to identify those opportunities to reduce the spread.
Thank you very much, Kara. Is there any questions for Kara or Jordana or Charlie? Okay, I'm looking at the clock. It's 3:32. There was one item on the agenda that I want to discuss first, and that's changing the meeting time from 1:30 to 1 o'clock to 3:30. Would you all like to do that? If so, raise your right hand. because we don't get through an agenda. Okay, well, we will do that. And recognizing we would like to have a hard stop, I will honor, though, the round robin. Let's give that no more than 5 minutes. Does anyone have something burning that they want to discuss? I know that, Tori, you want to start, and I know Greg Postman had a few things.
Thank you very much. Yeah, the first item that I wanted to talk about was there is still some signage out there that has the Let It Slide campaign still on it. And that was something that the city was doing months ago when we weren't seeing those visitors. And I don't believe the city is employing that campaign anymore, but I do see them still on some trailheads. And I would really request that we get some help in removing that signage. I don't know if you guys know what I'm talking about. There are signs that advocate for the fact that you can drop your mask when you're on trails and such. And again, we all like to think that's great, but the messaging is wrong. We are not seeing people put their masks back up when they're passing people. So I would make just a plea to the county to help us in removing the Let It Slide campaign signs. Those are no longer appropriate here. And then I have two questions. One, the governor made a statement about the 10 p.m. curfew that prohibited the sale of alcohol after 10 p.m. When does that go into effect?
It went into effect. Went into effect this morning at 9 a.m., if I remember right.
Today at 9? Mm-hmm. And then when do we expect this new county public health order to go into effect?
That's a Karen question.
Good question. I think we have, we'll have to work on the language tomorrow. So I would guess that we're going to need a little bit of time to turn that around. So our current order doesn't expire until the 30th. So we have a little bit of latitude, but we want to give, we want to let people know ahead of time that this is coming. So I don't have a firm answer for you. If you have a recommendation, I think, we can look at early next week. And just a FYI, Phyllis just texted me and said those signs are coming down today. The Let It Slide
thank
signs.
you very much.
Yeah.
Thank you.
Yeah, and Tori, that was commensurate with the discussion we were having on masks today.
Thank you.
Okay.
Greg, you had a few things.
Yeah, hi. Thank you. Two things. One is regarding the image you had of Brent, the mask campaign images that people are submitting. I want to thank everyone for participating. I just haven't seen them anywhere yet other than the one I repost. And so I'm just wondering where those are, if they've been implemented yet and if they're being spread on social media. These are questions I wanted to ask. And then I want to get back a little bit to very quickly, the risk assessment slide that Kara just put up. The question I had when I was looking at that is, it doesn't really account for outdoor versus indoor, does it? And maybe I'm missing something, but if, say, we have a school class outdoor or a restaurant outdoor, there's a different level of risk than indoor. And I'm wondering if that should be reflected in that slide. I'm not looking for an answer right now. I just wanted to bring it up, things that I noticed. Another thing is, I love Charlie's video histories of pandemics. And I'd love to see a series of short videos taken from those presentations that we could present. I think great material. The other thing is regarding one of the very early mitigation slides Karen showed. It talked about the possible negatives from a strategy. I keep thinking about all the people who are still feeling locked in their homes because they're afraid to leave because they may be immune compromised or just really fearful about catching this. So I wanted to put the positives on that slide. And I know you had them in your more detailed slide, but what are the positive outcomes? And we should probably talk those up while we're also speaking of considering the negative outcomes of some of these mitigation strategies. And one of the positives I've just been reading about is that we're probably expecting to see a reduction in flu and cold cases if everyone adopts the universal practices that the medical community has used forever on health. We're probably going to see a reduction in the flu and the common cold. I don't know if that's conjecture, but a lot of this is. I'd love to learn more. Finally, because we're not going to meet again for 2 weeks, tentatively we have there's a fashion show scheduled, a mask fashion show scheduled on the street in front of Metzaluna on Cooper Street for August 8th in the afternoon from 12 to 2. And the idea is to both normalize best practices and good behavior around masks, and model, innovative mask. So it's on the program. I don't know where they are with their permitting. Just wanted you all to have a heads up because it will happen the day after our next Board of Health meeting. And I think everyone should start thinking about their mask for a fashion show. Thank you. That's all I had. Oh, sorry, I did have one more. Excuse me. Regarding the change we just made to outdoor behavior and wearing masks, I want to make sure I don't think we did, but I want to make sure that if someone's outside riding their bicycle with a maroon belt or on a bike trail or a hiking trail by themselves, social distancing, they're not going to feel compelled to put their mask on for fear of being criticized or harassed. I want to make sure we haven't made it sound as if you have to wear a mask all the time in your car by yourself, for instance. Maybe that's just not necessary. And I want to make sure we don't cross that line, the common sense line, which I know is an ambiguous line. But I began to worry about that, so I can't wait to see what staff comes up with. I'm sure you'll do a great job. Finally, there have been an article in the Colorado Sun this week about how our public health departments around the state have been really subjected to a lot of harassment, stress, threats, death threats, some very nasty behavior. There have been some arrests. I know some of us in our community have received harassing or threatening letters, phone calls, things like that. Just want you to know it exists. And what I wanted to ask everyone is thank your public health officials and staff. They're on the front lines. They're doing a great job for us, and it's not easy. So I just want to express my appreciation for Karen, you and your staff, and everybody who's working double time to keep us all safe. Thanks.
Thank you very, very much, Greg. The entire board will echo that sentiment.
Amen.
Yeah, amen. So with that said, I don't see any other hands going up for round robin. So let's bring this meeting to a close, and we will see you in 2 weeks starting at 1 o'clock. Goodbye.
Or at the fashion show. Take care.